Hello, my name is Jack. I'm one of the paediatric trainees in North West Thames. I'm here today to talk to you about congenital heart lesions. This is part one of the talk, which is about left to right shunts. Apologies if there's any background noise. I'm here with my 4-month-old daughter who might cry and interrupt, and there might be some other background noise because there are other people in the house. So first of all, this is just the anatomy of the normal heart, which is important to bear in mind before we think about the way different shunts affect things. So you can see we're looking at the normal flow of blood, which goes in through the vena cava, both sides, into the right side of the heart, then goes through to the pulmonary circulation via the pulmonary arteries, goes through 2 sets of valves to do that, comes back around to the left side of the heart via the pulmonary veins, goes through the left side and up through the aorta. And you can see the proximity of the aorta to the pulmonary arteries here in the vascular bundle. That's important for when you think about PDAs. And you can also see the general spacing of things in the heart, so you can imagine where various holes will be. So it's worth coming back to this when you're thinking about the actual lesions we're talking about. So generally, there are 3 types of major lesion in the heart. So there's left to right shunts, right to left shunts, mixed shunts, which are kind of left to right shunts with a few extra aspects added to them, and there's obstructive disease as well. There are some other complicated, what we call complex congenital heart disease, but we won't talk about them in a lot of depth, and they can generally be put into these categories. So here you can see the 4 types of left to right shunt. You have ASDs, VSDs, PDAs, and AVSDs. And you can just see the anatomical change that you can find in each of these shunts here. If we talk about the ASD, what you have here is a hole in the atrial septum which allows blood to get across from the left atrium into the right atrium. Now this is usually a foramen ovale problem where that hasn't closed properly in the fetal circulation, but you can get an additional defect. Technically that's part of an AVSD when that occurs, and we'll talk about that in a moment. These are usually asymptomatic because you're getting a relatively small amount of blood going around with each pumping of the heart. But over time you can get right heart dilatation, and that's the atrium and the ventricle because it goes through the atrium, unlike in a VSD. And as such, over time you can get your findings on your chest x-ray and your ECG that you will have learnt about, like pulmonary plethora building up, cardiomegaly because of the right side of dilatation, and right partial bundle branch block because you're affecting the electrical circuit of the right side of the heart as it dilates. You can get a murmur across the pulmonary valve just because of the increased pressure going across it, and you can thus also get a split S2 that is widely and thick split because there's no change in pressure between inspiration and expiration due to the fact that you're getting pressure going across from the left into the right. Now this you can basically repair with a catheter, and you usually go in and put a device into the hole itself, but you do sometimes do an open repair. Usually this is when children are a bit older. It can really be any age. I've seen them done on anything from kind of 1-year-old to a teenager. Just to state, these things usually get picked up either on fetal echocardiography or more commonly because you hear a murmur in early life of the child, or even when they're older on. That's because there's a relatively small hole, there's quite a high pressure jet, and the loudness of murmurs is all due to the pressure, well not all due, but generally due to the pressure going across it. So there's the anatomy. If you just want to pause this and take a look and think about what's going on in the circulation here. We'll move on to VSDs. Now VSDs, self-explanatory again, it's a hole in the ventricular septum, so you don't have blood going via the atria, but you do have blood going into the ventricle, and it's usually a much larger amount of blood. So they vary in size. Small ones generally close by themselves and don't need to be managed really, but they do have a louder murmur that's easier to pick up because of the increase in the pressure of blood going across. However, with larger holes, you get a much greater amount of blood going across into the pulmonary circulation, and this will often cause heart failure type symptoms. So you get dyspnea because you're having to breathe more often to get effective gas exchange because the lungs are so plethoric and full of extra fluid, and that leads to also to failure to thrive because you're burning extra energy to breathe this fast. You also get extra effort on those breaths, and parents will often notice that the children are getting tiredness and breathlessness when they're feeding, because feeding and breathing at the same time is difficult, and it's much more difficult when you've got increased fluid in your lungs. When you examine, you can often get respiratory distress that we've noted. You get a big liver because of further backlogging of blood into the liver. You often get a loud P2 because you always get a gradual increase in pulmonary pressure. This particularly starts to occur around the 3-month mark. So between 3 to 6 months is when you really want to try and repair these if you can. So eventually, if you don't close them, you get a reversal of the shunt and you get icing mangers, and this can happen and used to happen more with teenagers, but now we're picking these up a lot earlier. The big ones don't have a murmur, so you don't pick them up on examination, but you will generally have discovered them on fetal echocardiography. But having said that, often they do present for the first time just with symptoms of failure to thrive and breathlessness when they're older. This tends to happen around, let's say, 2 to 4 months, and you really want to try and operate on them before they're 6 months old. The treatment for this is to optimise their calories, so they're growing, so they're big enough to have a proper operation, to use diuretics to reduce the amount of fluid that's going through their entire circulation and thus through their lungs, and reduce the load on the heart. And you often use respiratory support, which is often NIV, basically to take the pressure off their breathing so they don't burn all the calories off to grow. There are 2 operative approaches. You can put a device in, but generally we do them open, and you do what we call a patch closure. But you need some extra space of tissue to do that, so you need them to be a certain size. We aim for 5 kilos. So it's a hard balancing act between when you want to act on them before the pressures get too high, but whilst they've got enough tissue to actually do the surgery with. If you need to reduce the strain on their right side of their heart before that, you do what we call a pulmonary artery banding, and what this means is that you basically make an artificial pulmonary stenosis where you tighten the pulmonary artery so that there's less blood going through to the lungs. And there's the diagrams, just have a look at the circulation there. PDA is a remnant of the fetal circulation to deliberately bypass the lungs whilst you're in utero. However, usually it closes by itself. Sometimes it does remain open, hence the patent. However, they're usually not of concern, and we pick them up because we hear a murmur, and you don't normally need to treat them, and sometimes we over-treat these, to be honest. However, if they are large, you can get VSD-like symptoms, so all the same symptoms with respiratory distress. Because they're very common in preterm infants, what we tend to see is that we find it difficult to wean ventilation support that we've started on these infants for other reasons. They're about as common as VSDs, so about 1 in 500, and the murmur you hear is beneath the left clavicle, which is the position of the ductus, and it's usually continuous. And you can often hear it at the back as well. They have a wide pulse pressure because you've got blood, because you've got runoff through the PDA backwards, which basically reduces your diastolic pressure, and you increase your own systolic pressure to make up for that. And you often have high SATs because of the blood going back in through to the lungs. You medically manage as VSD with diuretics, etc., and maximising respiratory support and weight. However, you can also medically close them with ibuprofen or paracetamol or indomethacin, although we don't do that so much anymore. That's only successful max 50% of the time. Sorry, that's Mafalda giggling in the background. You can close with a device as well, just like you can with an ASD, but very, very rarely we close them with surgical ligation. But this is relatively high risk. You get side effects like chylothorax. And sometimes we can't close them with devices because of the shape of them. They're too tortuous or they're too wide and the device wouldn't fit properly. And the risk with the device is that it embolizes and ends up somewhere else where it's really dangerous. It can block off a whole blood vessel. So an AVSD is counted as a mixing lesion, but it's not just an ASD and a VSD, because you can have it with no VSD, and you do always have an effect of the area between the atrial and the ventricular septum, so the valve area. So the valves will always be somewhat abnormal. You can have 2 very, very slightly abnormal valves with barely any leak whatsoever, or you can have 1 joint valve, which basically got 5 leaflets rather than a 3 and a 2, and these often need full repair as you're actually doing the repair on the whole. It's very common in Down syndrome, so if you think about Down syndrome patients will have a 15 to 25% chance of having an AVSD, they have a 50% chance of having a cardiac defect in the most commonly AVSDs. It's very uncommon to have an AVSD without Down syndrome, although it does happen. It presents with the same symptoms as a VSD, often a little bit earlier, so let's say 2 months rather than kind of 2 to 4, but you do often get some low SATs as well because you can get mixing as well as shunting. So So with a big enough VSD and a shared valve, you essentially have a shared ventricle of sorts. These need repair, and preferably as early as possible, because once you start to get a raised pulmonary pressure and pulmonary hypertension, then you will have big problems once you shut the hole, and you'll get a massive drop in cardiac output post-op, and that's very hard to manage. So in Down syndrome especially, where they've got an increased risk of early pulmonary hypertension, then you need to try and close these before 3 months, although that can be difficult. So let's have a case to talk about what we've learnt. So here we've got a baby girl born by normal delivery. Everything was fine at the time, no murmur heard on her baby check. She's now 2 months old. Parents have noticed that she seems to be getting tired through her feeds and needs rest through them. And the GP has noticed that she's dropped off her centiles. So she's gaining weight, but very slowly, and dropped from the 75th to below the 25th. So the GP was worried about this at the 2-month check and sent them to you for a review. So when you review them, they've got normal OBS apart from their rest rate, which is raised at 66. You notice some moderate subcostal recession and a 2-centimetre liver, no murmur. So what do you think is going on here? Take a second to pause before we move on to the next slide. So this is very suspicious for a VSD. You can see the reasons here written down, the timing especially, and this will probably need diuretics and its closure as soon as possible. I don't think it's severe enough to need a PA banding, but before 3 months hopefully. So if you talk about what we've seen here today, we've talked about left to right shunts. So basically you have a hole in a normal circulation otherwise, and that means that you've got extra blood going through the lungs. The symptoms are all related to the extra blood going through the lungs, and failure to thrive because they're burning extra calories with their increased rest rate. And so the presentation, generally ASDs present later on in childhood, but VSDs in the first few months of infancy. And a PDA we tend to find out about on a murmur very early, but we kind of becomes a problem once you start to try and wean ventilation. And we basically treat by offloading fluid and maximising growth initially, and then once you can, you close the hole. Thank you very much. Thank you very much for listening, and hopefully you can read my next talk, which is about the right to left shunts. If you've got any questions, please email me at james.a.cooper08@gmail.com.